This is a story about how we introduced patient education in southeast London, and it's going to be warts and all. So this is all fact, and the focus of this is probably going to be a bit different from what you often hear about how structured patient education is delivered and how it's run, because this is about what people don't generally talk about. And the reason for that is that I'm not a professional healthcare professional, and I'm not an educator, but this will come apparent. So the title of this is Creating the Best Outcomes from Scratch. The fact is, at the end of this program, we achieved the highest reduction in HbA1c in the country, and we did that in the first year of delivering it. And we got over 1,000 people through in our first year. And we had nothing to build it on at all. So the moral of that story is anybody can do this if you want to. Now let me just try if this works. No? Oh, you see. Right. So the first question is, why are you doing it? There's a textbook, and you'll hear lots of stories around here about achieving better clinical outcomes and all that sort of thing. Yes, we had a need to introduce patient education because there was none of that in place. But actually, one of the things we were looking for in this turnaround program was we were looking for early success. And the reason for that is we wanted to create momentum for the change program we were doing. And because we didn't have patient education previously, we thought it'd be a relatively easy thing to do, to introduce something new that had been absent and we knew there was demand for. So we used this very clearly as an example to create momentum and credibility to do some of the more difficult stuff later down the line. So when you start launching your patient education program, I would also think beyond the clinical outcomes, because that'll help you think about actually what you're going to achieve. And that was quite relevant to some of the successes. The focus, first of all, was understanding the consumer's need. I wouldn't emphasize that enough. And I'd always try and ask people to think about their daily lives for the reason to focus on that. Because those are just two silly examples I've given. If you think of an organization that isn't successful, it's because they don't know what the consumer need is and they're not meeting it. If you think of an organization that is successful, they are absolutely passionate about it and they get right into the detail such that every decision they make is based on that premise and that alone. There's a lovely story from Steve Redgrave, how the single thing he put down to winning his 5 gold medals is they got rid of all the peripherals and they had one issue, which was, will it make the boat go faster? That was the only question they asked on every decision they made. So if you understand what they are and you focus on meeting them, you will meet them. If you don't, you won't. It's as simple as that. It becomes luck. So spend a bit of time thinking about who they are and what they're trying to do. So the first thing we did is we studied our geography. And I remember very, very clearly early on, one day when I asked the management in Bexley Primary Care Trust where the GP practices were. And they didn't have a map of where they were. And I was new and I didn't know where they were. So you've got to understand your population. And we found we had, up in the north here, we had a very different demographic up here to down here. So we tailored where we approached this to the population. So we had very specifically, we got involved in local groups in that northern area in a very different way to the southern, because they're a totally different population. So don't apply a generic solution across the whole geography. It doesn't work. The other thing was about transport. We had a really funny one on that. At our first venue, they dug up the road outside the car park. And outside the car park, you could still park on the roads. There wasn't a parking restriction. But what we found was, because they blocked the car park, people didn't go and park round the corner, they went home. So think really carefully about the implications of how people get to your venues and the implications of that. It is quite weird. We also worked out that people typically would only drive or travel about 1.5 miles. They wouldn't travel more than that. Now, this was a suburban environment, but that was what we found, and they weren't prepared to do it. Now, we didn't know that, we didn't expect it, but that's what happened. The venues is pretty obvious, but we spent a lot of time looking at that. And the detail you go into on all the basic stuff about how easy it is, how comfortable it is, not just for the attendees, but actually the people delivering it, because you need a decent environment for that to happen. And the more time you spend on getting that right, the dividends you will get back are huge. If you think you're running a program for a few years and you get a good venue, that's going to pay back. And the time you spend proportionally on that is really worth it. I talked about the GPs, and that's a function really of the reach that they have. What you'll find, and we'll see this a bit later, and someone was talking about it earlier today in another talk, is you will always find you've got hotspots. You'll find people who respond very well and those who are later on. So you've got to be aware of that and manage those hotspots and exploit them to create benefits to get the laggards to come with you. And you will have a variety. Again, don't assume everyone's there. You've also got to work out your marketing opportunities in your local geography, and they will be there, and your local press will support you on advertorials and stuff like that. The libraries, all that kind of stuff. It's quite weird. Getting stuff up in practices, we found, was quite difficult. Getting stuff up in libraries and public places was actually very easy. And getting those advertorials out there is quite important, because there's actually very little competition, where there's lots of competition in your GP practice, generally. He says, why is that not working? There we are. Right. Communication. If there's one thing I learned from this, and we didn't do enough of, then even though I thought I'd done a hell of a lot, we didn't communicate enough, and we didn't do it well enough. And any time since then, we've done more and more and more of it. Do not underestimate the value of communicating effectively. The healthcare professional awareness, there was a talk I just came to just now on Mike Tranell's one upstairs, I don't know if you were in it, when I think it was Naveed who said 56% of GPs don't believe that they can achieve behavior change. So if the healthcare professionals aren't conveying a message they believe, they're not going to get a response, and it's about conviction. So you've got a really big issue there of getting conviction and healthcare professionals to sell the message. And if you don't do it, they won't do it. And that's both the awareness and the understanding. I talked a little bit about the local PR. That's not just press, that's also patient groups and patient advocates. So when I talked about the people in the top of the borough, which was a much more minority ethnic group, and also a much higher deprivation, getting in with those local people was hugely important. That's the access in. And I know people talk a lot about patient champions, and Diabetes UK have done patient champions and stuff. It's immensely important. Don't pay lip service to it. Find the key person and exploit the hell out of them, and you will get them. They will be there, because they're generally very keen to do it. The other point was on the patient group. Our patient group grew enormously, and that has a pyramid effect, because it's not just the group, it's friends talking to friends talking to friends, and that's why that works. And you'll find that momentum of that triangle is really powerful, and that's what you're trying to do in your communication. You are using that to create momentum. Right. I'll make absolutely no apology for this, because I think this is what really made the difference. Because we knew exactly what we were doing and why we were doing it, we knew what we were going to focus on. So whilst people get fed up with measuring lots and lots and lots of stuff, the reason why we didn't get fed up with measuring lots and lots of stuff is because we made decisions based on the information we collected. So going into this in the detail, the referral process, the first thing we did is we made it really simple by creating simple forms and it wasn't just around education, creating templates to enable the healthcare professional to click a button made it so much easier. If they wanted to send a fax, fine, give them the option, but make it really easy for them to do. Likewise, we did self-referrals as well, so we made it easy for patients on those posters in the libraries and places like that, and the opticians, they could pick up a leaflet and it was easy for them to book. Really, really important. We have a remarkable ability to make it very complicated for ourselves because we don't think about the user and what they're having to do. We also, in that process, we worked out what information we wanted to gather at the early stage, and we made that reliable so that when the referrals came in, we had a consistent amount of information that we could use as basic input. Because one of the strengths and one of the things we liked about X-Pert was that it was information gathering, and we could use that. And that's why that was so important. And if you start that process right at the beginning, rather than try and retrospectively gather information, it's a lot easier. And everyone gets to understand it from the word go rather than trying to play catch up. And we measured absolutely everything on the referrals. We know, I said earlier, you'll get a few practices that really go for it, and you'll get some that don't. And you have to use that information to build the case for those who aren't. The support processes, of all the things in this, I think the support processes are probably the most important thing of all, and the least understood and the least invested in. It's very unfashionable to invest in admin, but this admin pays back hugely, and it's very inexpensive. It's just not very cool. The key that we did was, from the moment of referral to the moment of attendance, we worked out what happened. And we had some practices who would be referring people, despite everything I've said, just chucking them at the door. And we had to do quite a lot of work to ensure that the patient, by the time they started the course or to attend the course, we addressed their perceptions and got their perceptions right, because they may be referred, but they don't know why and what it's involving. And particularly with X-Pert, which is quite a big commitment, you've got to get that understanding of what the process is that they're going to enter into. And if you don't do that and you create a surprise, you'll get much higher failure rates and lack of conversion. So set those expectations early. And that's what those guys were doing, phoning people up all the time. There will be a cohort at the end, and Suzanne did a poster last year on this, where they did the follow-up of people who were unlikely to attend, and they kept nagging them, and there is a cohort who won't. And you just have to live with that. But you will convert quite a serious chunk of doubters by getting those perceptions right, which is what we did. And we also did the really simple thing of sending text. You can send text using nhs.net for free. You can do it from your computer. It's no issue at all. And that kind of stuff, be it a week before, be it the day before, the reminder makes a huge impact on attendance. And we had very, very high, we had much better statistics on that than we expected. Because we picked up the stats from Tower Hamlets, who had been the first lot to do this at scale, and we were much better than them, and that was a big surprise to us, but we got it right. We had big debates about whether to use clinicians, patients, and other people in the process of education, and one of the key things that came out and talking to a bunch of people was, you're not so much looking for the technical support, you're looking for good educators. And a good educator is worth more than an accurate technician. And so we worked quite hard to try and address that. And once we found a few that did it, we built on that. And that was the key thing that came about. And that had a huge impact on the patient feedback that we had. People liked coming, and they liked the messages because they were received in a way that was empathetic, and they bought into it. And that's why we think we got the results we got. The stuff that we collated, the data, and this will come on to in a moment, we turned into information. There's a big difference between data and information. Data is stuff. Information creates an opportunity to change a decision. And that's what we used it for. And I'm afraid I was obsessive about it, and it wound a few people up, didn't it? But it had an impact. It did have an impact. And the reason why we were obsessive about it is we knew what we were doing and why we were doing it. So each step of that process, and it's really important to separate each of them out, the different things that you measure and track and the impacts that they have. And if you break it down into that level of detail, you'll make different decisions and you'll collect different things, and you know what you're going to do with it. Because each of those steps will impact your outcome. It's not just going in a blank piece of paper. You've got to look at the referral, the chances of getting a referral. Is the referral going to be converted? Does the patient know what they're coming to? Are they likely to come? Do they want to bring an accomplice? I don't know what the right word is. Someone with them. There's a posh word for it, I'm sure. And the training and support for the people delivering the courses was huge. So again, just citing something that was said upstairs just now, if you think about the impact your trainer is going to have on the number of patients they're going to have over a period of time, that investment in training those people well and giving them mentorship in their early days has a huge impact. And I think one of the key things was the mentorship, because when we were scaling up, we did it very rapidly, but we gave support to those people to ensure that they were able to feel confident. And they need to be confident in order to roll this out. If they don't feel confident, they won't have the conviction, and it won't be delivered to the quality that you want. That, in a nutshell, is what you do. The technical stuff about X-Pert or whatever, you can go and get. But that's how we did it in practice. And in fact, it's public. There's another article in this month's Diabetes in Primary Care, which is over there somewhere, where some of this is written up in there as well, and you can see it. That is it.